professor. And also I would like to welcome the panelists, Dr. Muad from Saudi Arabia and Dr. Diaddin from Egypt. And we are excited to hear from you, Dr. Webster. Please go ahead and start your talk on management of the small renal masses. Mike is yours.
Thank you very much. Thank you very much, Ahmed. A great pleasure to be asked to give this talk. So my name's Guy Webster. I'm a consultant urologist in the UK, and I gave a similar webinar about 6 weeks or so ago on partial nephrectomy and techniques, and it was quite an operative talk. And so when I was asked to give this, the second one, I thought it might be interesting to give some sort of context of where partial nephrectomy fits in, certainly in my practice in the UK and that of most urologists in the UK who see patients in clinic and process them through what we call an MDT, the multidisciplinary team meeting. And a lot of our patients are increasingly elderly. And so we are seeing quite a lot of the small renal mass. I'm going to talk about the context of the small renal mass very quickly, just the staging to remind you. Then I'm going to talk about the imaging in terms of the diagnosis. I'm going to talk about cysts because they're very commonly seen. Angiomyolipoma and Oncocytoma. I'm going to talk about the biopsy, the role of the biopsy, which is becoming quite an important and fairly controversial issue at the moment in the small renal mass, with a little bit of a discussion about seeding, and then the management overall, and we can lead on to surgery through nephrometry scoring. For us in the UK, we have patients who are fast-tracked into the system. This is a standard form that our general practitioners in primary care fill in with certain red flag signs or symptoms to process them rapidly into the urology system. And you can see the fourth one down, it says palpable renal masses or suspicious renal masses on radiological imaging. And so that will result in a fast track into our system for the NHS patients. So we have to see them within 2 weeks, irrespective of age. Once they're referred in, we see them. Now, we're going to talk about small renal masses. This is a very large specimen, a radical nephrectomy. I did as an open specimen previously, just to say we do still see these, but in the UK, they're mainly historical, interestingly. We don't see much of this now, and I can explain why. Renal cancer, 7th most common renal cancer of all types in males, and we were taught at medical school, and we still teach the classic triad of abdominal pain, hematuria, and loin pain, which was present in 30 to 50% of cases previously. And renal cancer is increasing in incidence, perhaps 3% a year over the last 10 years. We know it's associated with smoking, obesity, dialysis, cystic tumors, probably hypertension. But the issue at the moment is the era we're in of imaging. And so our incidental renal masses account for over 50% of all our new renal cancers that are seen. And we've had a resulting stage migration, a down staging of these renal cancers from the previously symptomatic with hematuria or palpable loin mass to earlier incidental abnormalities. And in the UK, my estimate was that last year we probably requested about 7 million abdominal images of CT, MRI and ultrasound combined, 7 million images. So that results in potentially a lot of pictures of the kidney. And we know that there are subtypes of renal cancer. The vast majority are clear cell carcinoma, about 80% or so. But with the expertise of our histopathologists improving, we also start to see papillary types 1 and 2, and the lower aggressive chromophobe type cancer. Rare is the collecting duct type, which is a very aggressive tumor, and medullary carcinoma as well, which we've seen commonly in sickle cell tray, and is seems to be pretty common in the United States amongst the Afro-Caribbean population. But the imaging cannot differentiate these renal cancers. The TNM staging, which I won't dwell on, basically quantifies the tumors that are small as T1A. That's less than 4 centimeters, and that's what I'm going to talk about. So that's 4 centimeters in the greatest dimension and confined to the kidney. T1A. T1B is between 4 and 7 centimeters. That used to be the T1 category. So we've come smaller as we've started to pick them up, and T2 more than 7. So the spectrum of the small renal mass is quite extensive, from the one we can see on the left, which is a posterior exophytic mass measuring about 1.5 centimeters, 2 centimeters or so, to on the right, bilateral renal masses, on the left, homogenous and posterior, and on the right, rather more irregular and perhaps infiltrative. So a different scenario being bilateral. So our imaging has produced basically an epidemic of what we call incidentalomas. They're found incidentally, they're not symptomatic. Most of them are cysts, and cysts are very common, with an incidence of probably more than 30% from the age of 50, and not necessarily related to low GFR and polycystic kidney disease, just related to natural aging of the patient and their renal parenchyma. And we're talking about solid renal masses, SRM, small renal mass, less than 4 centimeters. And we know from studies that 20% of these are benign histologically, and more so, a larger proportion for the smaller lesions. And the majority of these benign lesions are oncocytomas or angiomyolipomas. And we also know that of the cancers that we see at this small size, only about 20% are high grade. So most of the cancers are relatively indolent and unaggressive. So we know from the natural history of surveillance of solid small renal masses that they grow probably about 3 millimeters or so a year, left untreated and kept under surveillance. And this was a study from 15 years or so ago now, when this started to become an entity of the surveillance of renal tumors. And the context of this is that the risk of developing metastatic renal cancer with a small mass is probably 4%, pretty low, 4%. But the risk of developing a non-renal second primary is 7%. So they've got a higher chance of developing another disease, which is more likely to affect them. So I would say that there is a case for saying that in patients greater than 70, although that's a bit generic, and we could drill into that, but small renal masses of under 4 centimeters quite possibly could be left alone in patients over the age of 70. Against that, we've got partial nephrectomy, which is a procedure which urologists who do minimally invasive surgery are very keen to do. Overall, we're aware that even in the best hands, there's a complication rate of perhaps 20%. Obviously, depending on the complexity of the cases and the experience of the surgeon. And these complications range from significant bleeding, which might require postoperative embolization by our expert interventional radiological colleagues, or even re-exploration, sometimes leading to completion nephrectomy. Urinary leaks, renal impairment, if a lot of renal parenchyma is removed and the patient already has renal impairment, cardiovascular complications, possibly a positive margin, although the significance of that is not truly known. And most studies have shown that if there is a positive histological margin from a partial nephrectomy, but the surgeon feels he has excised the tumour, you can continue to put it on surveillance rather than surgically go back in. I have gone back in for 2 cases with a positive margin, and both of them were negative. One had a completion nephrectomy and one had further partial nephrectomy, and neither showed any evidence of tumour, which backs up the literature. And then, of course, a partial nephrectomy could be performed and the histology is actually benign. So we have very good evidence, which I've based on EAU and AUA guidelines of using CT scanning, multiphasic contrast enhanced CT of the abdomen and the chest for staging. And in the UK, what we do is we call it triphasic. It's triple phase, 3 phases. We do a pre-contrast, we do a corticomedullary phase, which is about 45 seconds after injection of IV contrast, a nephrographic phase, which is the most important, after about 100 seconds. And what we're looking for is significant enhancement of more than 20 Hounsfield units, which is the category that the radiologists use to show how dense a lesion is. And the pre-contrast CT is vital to exclude hyperdensity. So this CT, this axial CT, shows a patient with a lesion in the posterior aspect of the left kidney, which is hyperdense. So there's no contrast in the kidney, as you can see, but it's hyperdense. It's already showing pre-contrast density, which means it's a cyst with a high protein content, or it's been infected, or with hemorrhage, and that can be left alone. But we can only tell that if we've got the pre-contrast CT. Sometimes we use MRI for patients with a contrast allergy, those with a low EGFR renal function, although they need renal function as well for the gadolinium contrast for the MRI, but sometimes the radiologist may be happy for them to have gadolinium, although that can cause problems with a condition called nephrogenic sclerosis. And we use it to identify patients, particularly if they've got tumour thrombus. So we're talking bigger tumours and greater stage tumours, but it's good for that and for identifying liver invasion. But it's also good when CT is equivocal at identifying the nature of our complex cystic lesions, which we see. So this these 2 MRI pictures on the left shows a cyst, the lower pole of the kidney on the left, and the picture on the right shows a large renal tumour in the right kidney with evidence of tumour thrombus in the IVC, quite nicely picked up with MRI. And it's important that we use the Bosniak classification of renal cysts, because we see them a lot. And I'm sure your case series are the same. So we've classified this from a radiologist called Bosniak, who set this up in 1986. And then it was modified in 1993 when he introduced the 2F, because it was thought that something intermediate was needed between 2 and 3. So this is the classification of cysts depending on how complex they are or not. So Bosniak 1 is a simple cyst with no internal contents other than fluid. 2, there's microcalcification or perhaps 1 septum in the cyst. 3, there are enhancing areas in the wall or in the septi, and 4, enhancing areas within the abnormality itself. And the reason this is important is because we can classify how malignantly they are potentially from the Bosniak classification. So Bosniaks 1 and 2, rarely malignant, we can leave them alone, we discharge them. 2Fs, we follow up actually for 5 years. We tend to use MRI just to limit the amount of ionizing radiation. 3, we consider surgical intervention, depending on the age and comorbidity of the patient, and 4 strongly suggest surgery. And we know that 20% of renal tumours overall are cystic. This sort of shows the same thing with simplified CT appearance, so increasing complexity to Bosniak 4, which is lots of abnormal enhancing areas within the abnormality. So the management is Bosniak 1 and 2, we can ignore and discharge. Bosniak 2F, we should follow up for 5 years and see if there's any interval change. 3 and 4 are considered surgical lesions, and we need to consider them for excision. Another modality used in some centres is something called contrast enhanced ultrasound, where the patient receives an intravenous injection of micro bubbles, extremely small micro bubbles, which are transported through the vasculature, and then the patient has a standard ultrasound with Doppler. It's non-ionizing because it's ultrasound. There's no evidence that these microbubbles cause any harm, and it's useful for patients who have abnormalities which are indeterminate on the CT. When we're not sure whether it's enhancing, whether it's a tumour or not, it's good for showing solid or cystic tumours. It's good for pseudo tumours where the patient might have a hypertrophic column of Bertin, a dromedary hump, and for the characterization of complex cysts, as well as to show areas of lack of relative blood flow, of ischemia. And this shows some pictures of top left. You've got a little bulge of the kidney in the left picture with a suspicion of it being a tumour. It's got blood flow, but the contrast enhanced ultrasound shows that it's consistently enhancing throughout with no change compared with normal renal parenchyma, and it is a congenital variant. It's a hypertrophic column of Bertin, can be left quite well alone. Now, the common form of tumour that we see that's benign is the Oncocytoma. On the left, you can see the classic appearance, and on the right, patient lying prone and having a biopsy into the posterior lesion of a different patient. And this has the classic scar in the centre, shown by the specimen on the right, and the oncocytic cells histologically. AML, small vascular lesions. They were originally classified as hamartomas, but now they're classified as what picomas, perivascular epithelioid cells, and they have a growth rate of normally about 0.2 of a centimetre a year, but in some situations they can grow up to 4 centimetres a year. And there's FDA approval in the States for these to be treated with mTOR inhibitor, everolimus, for those patients that have them that are 3 centimetres or larger and growing in size. They're associated either just sporadically, incidentally, but also with tuberous sclerosis and autosomal dominant syndrome, where patients have skin lesions, benign skin lesions, and neurological abnormalities, perhaps educational retardation, epilepsy, and also a rare condition seen in females, mainly through specialist centres, called lymphangioliomyomatosis, or LAM, where they get cystic abnormalities in the lungs. And the problem with these AMLs is not only is there a diagnostic issue on CT, but they can spontaneously bleed, something called the Wunderlich syndrome, where you get spontaneous retroperitoneal hemorrhage, which can be life-threatening. And this CT on the left shows the patient's left kidney surrounded by hematoma, confined within Gerotis fascia from a spontaneous bleed from the dark fat-containing lesion consistent with an AML, and on the right, the standard treatment, which is a selective embolization of the abnormality. Now, AUA has updated its guidelines actually this year on AML, and one of the things we looked at in our unit was the evidence for, what is the cutoff for indications for treatment. And classically it's thought to be 4 centimetres, an AML of 4 centimetres or more. So the AUA said this year, treat AMLs with selective arterial embolization or nephron-sparing surgery, in large tumours, it just says large, recommended threshold of intervention doesn't exist. Females of childbearing age, because of the hormonal changes that take place, they have an increased chance of spontaneous hemorrhage. And patients for whom follow-up to access emergency care may be inadequate. So, patients with poor compliance consider some form of definitive intervention. And those patients with persistent pain or repeated bleeds. And I think that's useful because I previously used to find it quite difficult to know, with it, particularly the small ones that you see. Now, to move on to the biopsy issue, historically, we had not many indications for biopsying renal masses. Single functioning kidneys, whether anatomically single or not, functionally single. If they were bilateral or multiple masses, those patients who had metastatic disease prior to starting systemic therapy in the absence of a renal procedure, so to get histology to see what the subtype was, or patients who have a coexistent malignancy to see whether this is a metastatic abnormality or a new renal abnormality. And it wasn't done very often, for the simple reason that most masses were large and they're predominantly malignant because they were large, and they needed to be removed surgically. So there wasn't really any need in doing a biopsy other than in those very difficult, challenging areas of single functioning kidney or bilateral multiple abnormalities. And the technique wasn't very good. It was fine needle aspiration, and we've moved on. And very poor specificity and sensitivity for malignancy. And there were reports of it causing significant problems with seeding, tumor seeding, which put people off. So now the renal mass biopsy, RMB, has become reasonably commonplace in some centres who advocate it really quite strongly for small masses. It's image guided, either ultrasound or CT. The advice is to take the peripheral abnormality rather than the central area where the necrosis is, because that will pick up more likely to pick up your histological abnormality. Avoid cysts because of seeding, puncturing, and it's not very definitive histologically anyway. This can be done under local anaesthetic with a coaxial technique. It's important that it's coaxial to reduce the risk of seeding. Take at least 2 cores of a centimetre or so. And now we have good studies showing very, very high sensitivity and specificity for cancer, and pretty good subtype concordance with the patients who have gone on to have ablative surgery, partial or total nephrectomy, and looking at the histology of the excised specimen. The grading, the Fuhrman grading varies. That worries me a little bit about how accurate you are with those, knowing they're small tissue samples, but reasonably good, and a pretty low complication rate of about 5% perinephric hematomas, about 1% transfusion rate, and arguably a very low seeding complication rate in the literature historically. The AUA is not particularly in favour of renal biopsies, and they say, well, it should be considered when a mass is suspected to be hematological, metastatic, inflammatory, or infectious. It's not required for young or healthy individuals unwilling to accept the uncertainties, or for old or frail patients who are going to be managed conservatively anyway, which makes sense. Full discussion should take place, counselling of the disadvantages, and they should have multiple core biopsies, not FNA. And the EAU says that a renal biopsy should be taken before ablative therapy and before systemic therapy, and there's strong evidence for that. There's very weak evidence for patients having one if they're considering active surveillance and serial CTs. You don't necessarily need to do that. Again, coaxial technique must be used in terms of the seeding issue, and don't perform it on cystic renal masses. Now, the EAU updated its renal biopsy guidelines last year to say, and this is quite contentious halfway down. However, authors recently reported 7 patients in whom tumour seeding was identified on histological examination of the resection specimen after surgical resection of renal cancer following diagnostic percutaneous biopsies. And 6 of these 7 cases were papillary renal cancer, although the clinical significance is unknown, and only 1 of the patients developed a tumour recurrence at the site of the previous biopsy. This paper is from Oxford that I was involved in, where we analysed all our renal biopsies, and we identified these 7 cases. At the time of partial nephrectomy histological examination, we saw there was seeding along the tumour, along the biopsy track. 6 of the 7 were papillary tumours, and there was 1 that was a clear cell. And this is important because the papillary tumours often have a different appearance on CT, more homogenous. That's one on the right. Whereas on the left, you've got the heterogeneous abnormality, a bit more like the renal parenchyma, which is a renal cell, a clear cell on the left and a papillary on the right. So in our unit, we try and not biopsy anything we think might be a papillary abnormality for that reason, in case there is this increased risk of seeding, because they are fairly soft. So we need to look at the characteristics of the patients to guide us as to how best to manage. So active surveillance for older patients with a limited life expectancy, multiple comorbidities, or renal dysfunction, or patients that refuse intervention, which some will. For ablation, ideal if the abnormalities are small and peripheral and ideally posterior, easy to access. Laparoscopic ablation seems to have somewhat gone out of favour because the interventional radiologists are able to hydrodissect the bowel off the anterior aspect of the kidney so they can develop a plane and treat the anterior tumours. Partial nephrectomy for ideally solitary kidneys, bilateral tumours. Radical nephrectomy for difficult tumour anatomy, complex tumours. Older patients with comorbid conditions and large tumour and fairly good renal function, which basically gives us an algorithm of a small renal mass, have a diagnostic evaluation, consider a biopsy, and if the biopsy is performed and it's histologically benign, no further intervention is required. Now, we can discuss that later. You know, benign, there's benign and there's less benign, which is an increasing topic for discussion in renal cancer. If the biopsy is not performed, or the biopsy is performed and the histology is malignant, then we've got the options of active surveillance in poor surgical candidates, elderly patients, non-aggressive histology, focal ablation, poor surgical candidates, elderly people, radical nephrectomy, patients unwilling to have a partial nephrectomy. Some of them just don't want to take what they perceive as a risk, either of surgery or of positive margins, or partial nephrectomies if it's technically feasible, particularly younger patients, long life expectancy, to minimize follow-up and to maximize renal function going forwards. But, you know, what is technically feasible? Because this is a huge spectrum. So, you know, the case on the right, a nice little exophytic tumor, which, as our oncologists say at our MDT, you could just sort of pluck off with a pair of scissors, although it's a little bit more difficult than that often, but it is relatively straightforward, whereas the one on the left is endophytic and more challenging, where complete excision would realistically result in access into the renal hilum and the associated vasculature. So to help us with that, we developed different units, developed nephrometry scoring systems, and there's quite a few of them. The most common ones are the 3 at the top, the renal nephrometry scoring system, the Padua, and the C-index. In the UK, we changed from renal to Padua, and the others, some of them are just for academic interest. One that's quite interesting is the MAP, it's the from the Mayo Clinic to do with how adherent the tumour is and how difficult it would make a partial nephrectomy. Certain things they look at, and basically they found out that in males with high body mass index, big tumours that were older, they're more likely to be more adherent and more complex partial nephrectomy, irrespective of the anatomical location, for instance, compared with females or with younger patients. And they vary in what they look at. We don't have to necessarily go into the detail. It's quite nice if for audit purposes the radiologists score them in the CT reports and when you attend your meetings. But it's based on anatomy and how exophytic they are, how far away from the hilum and the vasculature, and the size of them. So the historic indications for nephron-sparing surgery were elective, relative, and imperative. So there was the imperative ones. You bilateral kidneys, single functioning kidney, a bit like the indication for a biopsy. It's the same reason. Then there are the relative ones, the patients who have coexistent renal illness, whether it's urinary tract stones, diabetes leading to reduced renal function, or hypertension, which over time would lead to renal impairment, or the elective ones, initially a solid renal mass under 4 centimeters, favorably anatomically located at the poles, ideally the lower pole, perhaps upper pole, and a normal contralateral kidney. But that's changed now, such that we have the current status, which is that surgery should be offered to, it's the standard of care for a renal cancer that's localized, and we should be considering offering a partial nephrectomy to those patients with T1 tumors. So that's up to 7 centimeters, not just the small renal masses. Let me just move this out of the way. There we are. And things have evolved and had moved on from the radical nephrectomy 60 years or so ago by Robson. We then found out 20 years or so ago that patients had a partial nephrectomy have improved renal function, and we started to realize that the oncological outcome was just as good. And I quite like this phrase that one should never mistake minimally invasive renal surgery for maximally wasting renal surgery. Don't do minimally invasive surgery in a laparoscopic nephrectomy just because it's possible, but always try and do a partial nephrectomy when indicated for the patient to maintain renal function, whether it's open or laparoscopic or whatever modality. If a partial is indicated, try and do a partial nephrectomy. There's more than just the length of stay of the patient in hospital. I gave the talk on partial nephrectomy 6 weeks or so ago. I can just sort of go through these slides to finish the talk off in the next 5 minutes or so, of the principles of partial nephrectomy, of excising a lesion and then closing the defect. Things have moved on from open to laparoscopic, where we have short hospital stay, less bleeding. Robotics has come in with fantastic vision. It can even be done from the office. This is an extreme form of office urology, where the operating surgeon is outside of the OR. This is in Florida at the Global Robotics Institute, which I visited a few years ago. It's all about small incisions now, and the bowel is mobilized, the tumor's identified, the hilum is mobilized, the renal artery is accessed, the renal artery and the vein. The tumor is scored with diathermy, so you can see your margin. The artery is clipped with a bulldog to devascularize it, and the tumor is excised with scissors, making sure you've got a good view. Here's the tumors at the top of the picture, the renal bed with suction from a good assistant, so you can visualize, ensure your renal bed looks clear. and then close collecting system here if it's opened first of all, followed by the hemostatic suturing, perhaps with having taken the clamp off to reduce the ischemic time. Then close the defect from cortex to cortex using this sliding clip technique with these Hemalock clips on the sutures, and use procoagulants. Bolsters are not really used now, but flow seal or Tacocil tends to be used. And this sliding clip technique, I think, has been fantastic in terms of allowing the tension on the kidney to an appropriate level, so it doesn't cause ischemia, but it allows tamponade. And then it's put in an entrapment bag and removed so as to ensure it's a clean retrieval. So there's been a progression from hilar clamping to arterial clamping to early unclamping, complete zero ischemia or selective clamping, the use of intraoperative ultrasound, which is incredibly useful, and if units have it, to identify where the tumours are, particularly if they're endophytic. Contrast enhanced ultrasound, as I mentioned earlier. Immunofluorescence can be used. And these barbed sutures, which are useful. This is a picture of the intraoperative ultrasound. You can visualize it at the time of the console whilst you're operating. And this is the indocyanine green for the immunofluorescence. On the left, you can see the segmental renal arteries, which are highlighted nicely with the dye, so you can potentially ligate these selectively. And it can also help with identification of positive margins rather than inking in the lab. So to sort of show the progression as to where we are now, cold ischemia pretty much is historical now in terms of ice slush, and warm ischemic times are comparable to open surgery, 10 to 20 minutes in experienced hands, with minimal loss of renal function, fairly minimal blood loss in most cases, a couple of hours console time, 2 days length of stay, if not a bit shorter, positive margin rates under 5%, and a low secondary hemorrhage rate. So we've come a long way for those cases that are appropriate to do so. I'm going to stop things there. I hope you've enjoyed that sort of run through of the contemporary management of the small renal mass, from the diagnosis to the broad management, finishing up with surgery. And perhaps we can talk about some of these issues, some of which are fairly controversial. Thank you very much.
Thank you very much, Professor Webster. I really enjoyed your presentation. And I would like to call our panelists if they have any questions to you. And also I will be waiting on participants' questions. If they have any questions, they can send it to me. Well, till somebody asks you, maybe I'm going to start with some questions.
Yeah.
About systemicity scan for differentiate between tumors and the oncocytomas. Anybody using it nowadays? There was some talk about systemicity isotope scan.
Well, I have no experience with that whatsoever. In terms of isotope PET scanning, seems to have fallen out of favor in terms of diagnosis, because I think only about 30% of renal cancers are PET positive. So whilst PET scanning seems to have become incredibly popular in general oncological circles, and within urology, you know, certainly in the staging of TCC, transitional cell carcinoma, and prostate PSMA PET scanning, I think that's limited in renal cancer, but I have no experience, so I've slightly dodged the question there. I don't know. I'm not aware in the UK that we do.
And how common is the contrast enhanced ultrasound in your practice? Because We don't see it commonly here with our radiologists. Should we encourage our radiologists to do it, or what's your take on that?
Yeah, I think it's something that's available perhaps in the big centres, driven by an interested radiologist who does the scans, you know, themselves and are very hands-on. So it's not widely available. It maybe it's a bit of an academic tool, but I'm sure we've all got experience of some of these renal abnormalities that, you know, they've got a CT and we can't quite tell whether it's abnormal or not. We might do an MRI scan and we're still not sure, and we sort of feel we want a bit more information. We don't particularly want to subject the patient unnecessarily to surgery. Let's say they are, you know, comorbidly unwell with significant cardiovascular disease, and you sort of think, well, it's just nice to have something else. Is there something else we can do that might help? And sometimes it does, but no, it's a bit niche, a bit academic. But sometimes it can help, but it's not widely available in the UK. It's really just teaching centres and interested radiologists.
All right, Dr. Muaz or Dr. Dia, you have any questions?
Good evening, Dr. Webster, Professor Ansayar, and Dr. Muaz. I would like to ask about the role of PET scan in questionable masses, because last week I had a patient, about 6 years old, male. He had a history of acute loin pain with fever that escalated to 40 degrees Celsius. He responded well to intravenous antibiotics and antipyretics. On further CT scan with contrast, he had multiple cysts. One of them looks complicated with septi and marginal enhancement. The radiology report was not so decisive. We had him have a PET scan, which gave us equivocal results. They told us that there is marginal activity in the wall of this cyst. Actually, it was a huge one. It was central and it was about 7 centimeters. So I went for radical surgery. I didn't receive yet the pathology report, but on site it looked pretty malignant. I don't know if this is due to the stormy history and the inflammatory process, or was it a right decision? And if I have any option to do another investigation before going through this surgery.
Well, I'd be really interested to see what your histology show. Perhaps you'll let me know the answer to that. That is really interesting. So we don't, yeah, I mean, we don't use PET scanning routinely for renal masses. We started to use it more in a retroperitoneal disease to see whether it's active or not. But my understanding with PET is that it can be abnormal in inflammatory conditions. You know, FDG PET is abnormal in those conditions as well. So I mean, I just wonder, you know, if it's cystic, does that mean there's a bit of inflammation there? I mean, I mean, it's going to be fascinating to see what your histology was, and I'm sure you discussed with the patient.
Actually, I opened the specimen on the table. Actually, there was some soft tissue within, and I think it will be malignant, of course, but I was asking particularly about the PET scan, whether it was useful or not, and I think it didn't give us any diagnostic hints.
No, I mean, we don't use it because our radiologists say it just doesn't really help in the setting of renal cancer. But I don't know. I mean, that's a fascinating case. It's difficult to know. I mean, I think, you know, if your kind of gut feeling is that you think this looks abnormal, particularly in the situation of a normal kidney the other side, I mean, your hands are forced a little bit, aren't they? And, you know, you say to the patient, look, there is a chance that the histology is benign, but, you know, we don't want to leave it. Did you do MRI as well as CT, or just CT?
I don't know if it will be much of help, but actually I'm relieved for my decision. Surgically and intraoperative, it looks very bad. So I wouldn't make a partial nephrectomy and then wait for the pathology report. I think this would be so faulty. Interesting.
Well, yeah, well done. I mean, sometimes you just got to trust your training and your gut instinct, and you know, go for the feel of the situation, haven't you?
Dr. Muad?
Yes, I have one question regarding small tumor and endovascular clamping, selective clamping. Do you have any experience about this?
Well, what you mean? Tumors less than 4 centimeters and then doing selective clamping?
Yes, selective endovascular selective clamping. By the radiologist, they will put just a catheter, and they will select the small artery which is going to the tumor itself, and then we do just a small dissection for the pedicle in order to avoid much dissection. And before tumorectomy, we just do an occlusion, selective occlusion to this small artery. Do you have any experience regarding this?
No, I've got no experience of that. That sounds very interesting. So they put a little micro catheter up, do they, in the radiology department preoperatively, and then you can identify that. No, I've got no experience of that. There was a time, we've probably all gone through a phase of wondering whether we should preoperatively embolize our big renal tumors, and the evidence, I think, is that you don't really need to do that. But I did some cases where some of the bigger tumors, I was incredibly thankful that they'd been embolized, because I could palpate the renal artery because of the coils and the abnormality within the renal artery, because they'd been embolized preoperatively. And this is a sort of similar principle, isn't it, that you described, that your radiologist is doing, albeit selectively. But that sounds interesting. No, I mean that's very sensible. But I've got no experience in that. I've done, my partial nephrectomies tend to be renal artery clamping, some more selective arterial clamping. I'm not transplant trained, and my experience is that the transplant surgeons are really extremligly good at dissecting into the hilum of the kidney and getting very selective arterial ligation. I'm interested. It's interesting. I previously worked with Mahmoud Al-Akra, and I'm wondering whether he's listening in on this call, because he was a very expert transplant surgeon, and I did some cases with him where he showed me his experience of how to follow, the arterial branches in to the kidney to try and get them as selective as possible for small tumor partial nephrectomy. But most people tend not to do that. You don't have to do it, but I think by doing it, you will maximize your retention of renal parenchyma, which is the goal of partial nephrectomy.
Yes, I think we, with Dr. Nicolas Dumerc in France, the ideas came for the transplanted kidney. And the transplanted kidney showed there is small renal tumor around 2 or 3 centimeters in the upper bole. The problem with transplanted kidney that you would like to avoid dissection of the renal pedicle, because the risk of injury is very, very important. In this case, we did a total occlusion by using the catheter from the radiology. The radiologists, they put the catheter before the surgery, and the patient then shifted to the urology OR. And at the same time, it was a very nice idea, because we don't need to dissect much. In this case, I would like to know whether, if we did it systematically for certain patients, for example, patients who have unilateral kidney, or for patients who have renal insufficiency, and you would like to avoid much dissection to the renal pedicles. We did it 2 times, and we feel that it's very nice. We don't have much experience regarding a lot of patients.
You should have you. I mean, I'll look into it. Have you written it up? I mean, it sounds like a great technique to explore, to think about. You should consider writing it up. I'm not aware there's much in the literature for that, but I think anything that helps, particularly with a difficult transplanted kidney, in terms of identifying the vasculature, is beneficial.
There's one question from the audience about when do you consider Professor RFA on a small renal masses? You think is small and looks not so aggressive, would you consider radiofrequency ablation?
Yeah, so I think so. It depends on the expertise of your local interventional radiologists, and whether some of them are offering cryoablation and some of them are offering radio frequency ablation. My experience is that the cryoablation seems to work better. You can see the visualization of the ice ball at the time of the treatment. And I think the series have shown there's been more collateral thermal damage from RFA to ureters than with cryo. So if you've got a patient who is considered elderly and somewhat unfit, and the tumour is under 4 centimeters, that's the cutoff from our radiologists, and it's anatomically in a favourable position for them to access posteriorly and a polar lesion, then they're happy to ablate them. Now, what I find interesting is, what constitutes an elderly patient, certainly what constitutes an unfit patient. Partial nephrectomy is a big operation, but it's not major surgery like major neurosurgery or cardiac surgery. How fit do you need to be to have it? How unfit do you need to be? But I think that's something we just get a sense, don't we, when we see the patient in the outpatient clinic, and we think they are somewhat unfit with comorbidities. And we factor into that the fact that we don't have the long-term data of ablation. So, we don't know if it's as good at 20 years. And if the patient's 70 or 80, we know we're going to get them through their lifespan by ablating them. So I think ablation offers a very good alternative to those patients.
All right. Actually, I have a question for you. When the pathology comes as a positive margin, which patients you would follow up and which one that you're going to go back and take out the kidneys?
Yeah. So the issue here is that the process in the UK is that the patients are discussed at a multidisciplinary team meeting afterwards, at which there are oncologists present, and the oncologists tend to be quite aggressive with patients who have a positive margin from most forms of surgery, non-urological surgery. And I mentioned earlier on, I've had 2 cases, and I think this depends on the honesty and the experience of the operating surgeon to know whether they truly feel at the time of the surgery whether they obtained a negative margin or not, because I think the surgeon will know from visualization whether it was negative or not. Sometimes, and for reasons I don't fully understand, histologists will say no, there seems to be, not obviously they can't tell the tumour still present in the remaining renal bed, but it's up to the resection margin. But I think the evidence is that certainly if you've got the pseudo capsule, it's excised, I think that's sufficient. But if you think surgically you removed it, then I don't think you need to go back in. I've done it twice, and they're but forced by the oncologist to have a look because of a supposed positive margin, albeit 2 years ago, about 5-6 years ago. Both of them were negative. There was no evidence of tumour at all in either the completion nephrectomy or the secondary resection. So I think the evidence is you don't need to go back in, but you should follow it up fairly closely with 3-monthly interval CT scanning for 2 years.
There is a question from the audience about urine leak, post-partial, if there is a significant urine leak, and whether you stent your patients or not if you think that you're going to go into the collecting system.
When I first started doing partial nephrectomies, which were initially open, my experience from my overseas experience in Australia with David Nichol, we would stent the patients in whom we were going to do a major resection into the collecting system. Sometimes then when I started to do minimally invasive partial nephrectomies, I would feel I needed to put a stent in at the time antegradely, which can sometimes be really quite challenging. But with the increased vision, certainly with robotic surgery and with bloodless devascularized kidneys, and you get such good vision of the open collecting system, if you see that, to close it or to do a very good thorough closure, two layers I tend to do of the renal bed. You tend to close everything. So in my hands, the renal leaks are fairly low. I'm not a massively aggressive partial nephrectomist into the hilum with any form of surgery, particularly robotic surgery. So maybe that's why the renal leaks occur less. So they tend not to occur because you see them. If you do get one, then retrogradely stent and leave a stent in and it will settle down.
Perfect. One other question from the audience about upper pole tumors. If not invading into the adrenal gland, do you take it out or not?
So what I tend to do, if the adrenal gland is not looking abnormal on the CT, I would leave it. So I'd always leave the adrenal in situ. If there's evidence of direct invasion at the time of the surgery or an abnormal adrenal on the preoperative scan, then I would remove it as per the guidelines. So I normally try and leave the adrenal where it is.
All right.
Even for the upper pole tumors, those that are not directly invading.
Any questions, further question from our panelists?
What I'm interested to know, what in Saudi, whether you were believers in the renal biopsy or not. It's a very contentious. What about in Cairo? What about in Cairo? Are you doing renal biopsies for these small masses at all?
Actually, we are still sticking to the old school, the classic school. When there is suspicious lymphoma or something, maybe it's part of systemic disease, or if it's inflammatory. But if there is even small renal tumor and it's enhancement, we would go to definitive management. I didn't do much biopsies.
I mean, and the other issue I don't think I mentioned earlier on, that there are some patients in whom you do a biopsy and you get quite an intense peri-tumor fibrotic reaction, and it can make the partial nephrectomy really, really very challenging. So, I think the bottom line is, if you think you're going to need to take it out and do a partial nephrectomy, you go on and you take it out, don't you? If you're looking for a reason to try not to, in an elderly patient that you're going to consider for ablation, if you can offer an ablation service, then perhaps a biopsy is indicated. And for those patients who are very elderly that you're going to just put on surveillance, well, you don't need to biopsy them either. So I do think in the UK we've moved from doing more biopsies to now moving away from biopsies and finding our place for them. But I think what you just said is very sensible.
Actually, we are not resorting much to local ablative therapy because we don't use it much here in Cairo. So most probably we are going to definitive either partial nephrectomy or radical nephrectomy according to the situation. That's why maybe we're not using much renal biopsies.
Yeah. It's good for urology, good for the service, isn't it? So I mean, if you have a very aggressive interventional radiology department, and some urology units are in the UK, the leaders in ablation, Southampton, David Breen, and the Royal Free, the vast majority of their small renal masses are treated by ablation, which takes all the fun out of doing partial nephrectomy, because you only get the really difficult ones to do.
There is one other question from the audience about masses and renal mass in a transplanted kidney. How would you approach that? Would you still do it robotically or open? Or?
I have no experience of doing transplantation kidneys robotically, and I think because of kind of lack of familiarity with with the anatomy, I'm happy doing it open. I've got no experience in doing that minimally invasively.
I think in France we did one case with the robotic partial nephrectomy, but it depends really on the localization of the tumor.
Yeah.
If the tumor is in the medial side, it will be easy for the robotic access, but there will be always the difficulty for dissection for the pedicles. But if the tumor it is in the lateral side or it is not far away from the skin, at that time it will be very difficult because you have to mobilize all the kidney. I think the situation is very different in the transplanted kidney. It depends on the adhesion, it depends on the patient. It's a challenging case.
I think that, as I said, I don't have specific transplant training in my urology experience in my urology training, and I think those are really challenging cases that require a lot of specific expertise. But the bottom line is like a horseshoe kidney, which in a way is similar. You never quite know what you've got in terms of the arterial anatomy. I think you've got to be extremely experienced and brave to take those on robotically, because the default is just to do it open, isn't it, and be comfortable with your exposure.
I think whether it's robot or open, the problem is to mobilize the kidney. This is very difficult situation because sometimes you may have a significant injury to the parenchyma and you have severe bleeding. In this case, your life will be difficult, whether it's the robot or it is open.
Yeah.
But really it depends on the localization of the tumor and the accessibility. Is it accessible for robot or only accessible for thermoablative treatment?
Yeah, no, they're challenging cases. I mean, and that, and we're going to see more of them, aren't we? As there's more transplantation,
Exactly.
More imaging, more surveillance. We are going to see more of them. So I think it will become fairly commonplace, and with time and with experience, it'll be less challenging. But at the moment, they probably need to be funneled into the specific centres for the transplant centres for that treatment.
Any further
Very good
questions from the panelists?
Good questions.
Well, I guess there is no more questions from the audience. And the panelists, I would like to thank you, Professor Webster, for this great presentation and very, very informative discussion. So thank you very much at this time, and you share your experience with us. And I would like also to express my thanks to our panelists, Dr. Muad and Dr. Diaddin. It was a lovely evening, and I wish everyone a great night.
It was a pleasure.
Indeed, thank you very much for giving up your evening, and I'm very grateful to you all, and thank you to Shobit and Saudi German for putting it on and organising it, and to the panelists. I always learn something from. I hope it's been useful for you.
It was very useful. Thank you so much.
Thank you very much. Thank you very
Fantastic. Have a good evening. Rest of the evening.
Bye bye.
See you next time. Bye bye.
See you.
Bye-bye.
Bye-bye.